Perfect. Hello everyone and welcome back to another episode of Physio and Live. What number are we?
I think we are on episode 17.
So another episode 17. We're just here outside the shopping centre, about to go in and get the last bit of Christmas decorations. Christmas decorations going up next week in one or two of the clinics if we can get around to it. All of the clinics. Yay! Love decorations.
4 Christmas trees! Woo!
So I hope everyone had a busy weekend shopping, getting all their gifts at reduced prices. Any news this week?
Any news this week?
The gossip.
Well, you gave them the first news, so we're a bit traditionalist here at Physio, and we're not putting up our Christmas trees until it's December. Which is a bit against the norm because I think all of the businesses in the towns nearly have them up. But anyway, next Saturday we're going to spend our Saturday decorating Christmas trees, so watch out for that, particularly in our draw clinic, because it actually has the window display. So we have one open window. All of our other clinics have wraps on their window, so we enjoy doing something a little bit different in the window in our draw, so watch out for that.
You say we. You say we.
I was just going to say it.
It's definitely not we.
Yeah. Ollie puts up the Christmas decorations on the tree and I take them back down again.
Yep. Do it wrong once and don't be asked again. That's my motto.
Yeah, I'm a bit of a one-man man. He'll put the tree up and then that'll be it. But anyway, we'll get that all done next weekend. And things I think were pretty quiet this week, weren't they? No real dramas.
Nothing out of the ordinary.
No. The Ducas magazine, if you've seen the little video that we posted last night, came out. So that's the community book that they do. I think it's the team in Ardra that do it, but it's based of all of the news in Glenties, Portneuf and Ardra, and God, there's a lot in it this year. We were flicking through it last night and we tried very hard to try and we were asked to write a piece and we were both really reluctant, weren't we?
Yeah. We
just kind of thought, oh, we don't know what to say. We don't really know what people want us to say, or but anyway, the person that asked us, Stephen McCahill, shout out to him, he just was taking nothing but yes for an answer. So anyway, we put together a piece and it actually came out okay, we think. So you'll see us in the Ducas this year just talking a bit about kind of how we got to where we're at now. A
little bit of our journey, a little bit of the road to getting where we are. Anyway,
back to business here.
So we're just going to answer some questions. We've had one or two questions in from the same person, kind of around the same topic, so we'll just chat briefly around the topic and see if we can give them a little bit more information. It's in relation to osteoarthritis of the knee.
Just before we get into that, someone has just asked, yes. Hi Deborah, thanks for watching. The Christmas sock competition, and actually this week in our classes we'll make sure that all of the physios announce the details of it. So every year in Physio Erin we do a Christmas sock competition. It's a bit of fun, a bit of crack. This year we're running Pilates right up until the week before Christmas. So the competition will run from Monday the 18th of December to the Friday the 22nd. Alright, so this year in every single class, so in every single Pilates class, the best Christmas socks, as judged by your Pilates instructor, will win that class for free. So there's a free class in every class. Best socks, one free class. And then there'll be an overall winner across Physio Erin, and that person will win a month of free classes.
To start in January.
To start in January, yes. So everyone in our Pilates, you need to have your Christmas socks ready to roll for the starting on the Monday morning, the 18th, right through to the 22nd. Alright, so it's the week before Christmas that we're running it, and we'll tell everybody in the class this week. So, and we would just like to say, from a judging point of view, the points are going for imagination, creativity, and something a little bit different. Individuality, yeah. So imagination, creativity, and individuality, that is what the judges are looking for. Last year's winner, we were going to do a big shout out to Marie Braddon, who last year got a hand knitted pair of Christmas socks done for the competition, and they were really beautiful. So we'll post up, that'll be sort of our poster socks for this year's competition. Anyway, that's enough about that. So Christmas sock competition, Deborah, 18th of December. Alright, and if you do multiple classes in the week, every class you could win. Alright, but don't expect to win with the same pair of socks. So if you come to more than one class, you might have to have more than one pair of socks. Okay, so sorry, Ollie,
You
for
can
cutting
swap
that up.
socks and share socks between people who go to different classes. Don't know
Oh,
how
you can't,
hygienic
but-
it is, but
But the instructors will be aware of the class, because after every class we WhatsApp each other the winning socks. You know, so if you want the individuality and the winning anyway, we're going on and on.
okay.
I swear there was a big prize for it. We should get a trophy.
Probably should. Yeah,
We might get a trophy. I'll have to run that.
we'll see. We'll see.
Run that through the accounts department to see if it passes. Okay, so just the usual, guys. If there's any questions you want us to answer as we're going along here. Hi to Gret. She's in Vienna. We're not one bit jealous. Oh, we're sitting outside Briarhill Shopping Centre in Galway, and it was miserable. Our plan was to do a lovely walk through Barn Woods today.
Yeah, it was just
Took
lashing
down me
rain.
wellies the whole way from Donegal, and it was miserable. Anyway, thanks for tuning in. So, the first question, Ollie, what was it about?
Yeah, it was about osteoarthritis in the knee, wasn't it?
It was, yeah. I'll just get the wording of it here. So, a patient sent this message in during the week, and again, if you have any questions while we're yapping here, just let us know. The question was, I've been told I have osteoarthritis in my knee. What does this mean? Am I going to have to get a knee replacement, and if so, when? Okay, so this one is all about knee arthritis.
Tomorrow. Joking.
Oh.
Sorry, no. Go on. So, what is knee osteoarthritis?
Okay, so this is
Is it normal?
a real topic that I am really interested in. I was lucky enough to be part of the OA group in Brighton when I started off working first, and I used to do the educational component. So if patients were referred in with hip or knee OA, then they used to come into my class, and I would spend the first session with them just educating them about what it is. And my biggest bugbear with osteoarthritis is that patients came in fearful because they were told either they had wear and tear in their joint. I hate that term. And the second thing was that it was bone on bone.
Yeah.
Okay, so just to be 100% clear here, osteoarthritis is the normal age-related changes of bone through our lifespan. Our hips and our knees are usually most affected because they are the large weight-bearing joints in the body. Alright, so osteoarthritis is nothing to be scared of. It is normal, and as we go on in life, we are all likely to have these changes. What differs is how much somebody is impacted by the osteoarthritic change within the joint. So there's a few things that will make us more susceptible to having pain in our joint from osteoarthritis. To be clear here, when we have a joint like a knee or a hip, two bones come together to form the joint. So in the knee, it's a hinge-like joint where you have your shin bone at the bottom and your thigh bone at the top. At the end of the bones, there's something called cartilage. And at the end of the bone, it's a very shiny surface of hyaline cartilage, which allows the bones to glide and slide together. So in real life, it's not bone on bone, it's cartilage on cartilage. The cartilage ends touch. Okay, there's no space in the joint really, it's filled with fluid where the cartilage comes together. That cartilage, and I'm harping on here and trying not to give too much detail, but the long and short of it is cartilage doesn't have a direct blood supply, which means that its capacity to repair as time goes on is not great. It does not heal as well as bone would heal because of the blood flow. The way that the nutrients get into the cartilage, it diffuses instead of a direct blood supply.
Mm-hmm.
So that means that over the years, the cartilage will normally change as we get older, like our skin does, like our hair does, and because of the poor blood supply, it doesn't repair very well. And that condition within the joint is known as osteoarthritis. Now, our bodies are amazing things, and they will do their very best to help with the situation in front of them. So somebody with knee osteoarthritis will come into us with a knee that looks a bit bigger, and they'll be nearly fearful of that, like, oh, look at the size of my knee. But actually, it's really clever. Your body, the bone underneath the cartilage, recognizes that the cartilage is wearing slightly and decides, right, I'm going to help this, and it grows into the joint slightly. And on x-ray, you'll see uneven little bony spurs, and everyone is like, oh god, those bony spurs. But that's your body trying its best to support the joint. It's actually really clever. The problem is that does cause thickening of the joint, and also our bones are full of nerve endings. So when we weight bear on those joints, it can be sore. The other thing that happens is the ligaments, which are the tissue that connects the bones, they will recognize that the joint needs a bit more support and get a bit thicker. So you'll end up with thicker ligaments and bones that sort of have little edges on them, bony spurs that are trying to help support the joint.
Stiffen the joint a wee bit.
That causes the stiffness. Yeah, so you have a bigger joint which causes stiffness, and because bone is trying to compensate, then that means you can get pain when you waver on your joint. But again, this is all your body trying to do its best to help the situation out. Now, over the years, we have developed interventions to try and help the situation, and that's where joint replacements have come in, and it has absolutely revolutionized how people can function after they get symptomatic joint arthritis. And just to be clear, I remember very well when I was a junior looking at an x-ray of a patient before I met them, before they came into the department, and I brought the x-ray up on the system and I seen it, and oh my god, the knee x-ray on the system, it was the worst case of joint arthritis I had ever seen on the x-ray, to the point that I was calling over my colleagues, shout out to Louise and Brighton, I was like, look at the state of this knee. And the patient walked into that department, no limp, no pain in their knee, they were coming in with elbow pain. The x-ray was taken 2 months before, just the GP, he said he was getting a bit of an ache on the inside of the knee, and the GP ran the x-ray. Patient was getting no big problems with that knee. So the changes on x-ray, or even in a joint that you can visibly see, does not equal pain always with arthritis. And likewise, I could see someone who's having a lot of pain with their arthritis and doesn't have those major changes on x-ray. So the two don't go hand in hand. There's a few factors though that do contribute to patients having more symptomatic arthritis. It is likely the older we get for it to be more symptomatic, so age. There is a genetic link to osteoarthritis being symptomatic. There is patients who have been through trauma with a joint before, so that trauma could be a fracture. So if you fractured one knee and you didn't the other, you may be more likely to have symptomatic in that knee. Or say you were a footballer and you had a bad ligament tear or an ACL replacement, then unfortunately that would constitute trauma, and you may be more likely to have arthritis in that knee than the other.
So what about someone that they say, oh, they did a lot of running, or they've just been really active all their life? Does that necessarily...
No, it doesn't. It's
actually the opposite, isn't it?
It's the opposite, yeah.
Recent research coming out
there's
saying that...
no link between road running and the development of osteoarthritis in the research. It seems to be that if you're totally inactive and you have maybe a larger BMI, so your weight is another factor. So if you're inactive and you don't have the strength in your muscles and you're slightly overweight, that leaves you a bit more susceptible to knee arthritis. And then on the other scale, if you're elite athlete level or you played sport at a high level, that probably does leave you a bit more susceptible. But it's not just one factor, it's multi-factors. So if you did a lot of sport in your youth, if you have a family history of arthritis, if now you're maybe a little bit more overweight than you were when you were younger, it's the combination of factors that will make you more likely to have symptomatic arthritis. I hope that's making sense. So it's not clear cut, but
so what can I do for it? Is she likely going to need a joint replacement?
This is interesting. So the first look, ultimately, if you are being massively affected by your knee arthritis, then joint replacement really is a gold standard resolution to the problem. Now, people do get frightened of knee replacements and hip replacements because they think it's major orthopedic surgery, but we have seen the results of great surgeries. Yes, everyone is going to tell me a story about a knee replacement that they've seen was really stiff or really painful afterwards. It's major surgery, it's a risk, but if your knee arthritis is massively affecting your function, it's totally and utterly a risk worth taking. So when this lady asks, do I need to get my knee replaced or when? That decision is solely up to you, the patient. The new guidelines are telling us that it is not about the consultant's decision. It's not about your weight. They used to have a restriction that if you were over a certain weight that you couldn't get your knee done. That's gone. It's now your choice. It's not about the x-ray, it's not about the physio, it's not about the doctor.
They can help you make it
exactly.
in making your
and
decision,
we'll guide you.
Explaining it and guiding it.
Absolutely.
You're not on your own, but
ultimately
it's your call.
It's your call. And what we talk to our patients about is how much is it impacting your life. So if my patient tells me they're not sleeping at night, they've stopped doing the things that they like to do, they can't get up and down off the floor, then that's somebody that I'm going to be saying, look, go to a consultant and talk through your options. If somebody is, it's only niggling them every now and again, then they might want to push that off down the line. We argue about when the right time is. You would say get it done when the knee is...
I would tend to err on the side of get it done a little bit earlier than wait until it's wait until your quality of life is severely impacted, where it's a lot harder for you then to get the joint replacement and get yourself back up to that level. But again, it's very individual as to how much someone is affected.
But we would say do not get to the point where you are limping, where the leg is getting weak. That's like, in our experience, that makes the job the other end harder.
Yeah. So we'll say, take for example, someone that plays golf, whatever, if they stop playing golf for a year or two because the knee is just getting too sore, don't expect after 2 or 3 years of not doing that exercise, not doing that regular walking, to expect to get the knee replacement and just go back out again and start golfing straight from the off. For me, I would prefer, if that person is noticing that they're getting difficulty in golf, they're looking at trying to strengthen the knee, they've tried conservative management but it's not working, get it done rather than wait for your quality of life. As I said, your activities decline massively.
And I'm gonna tell you now about an argument that's happening actually in our house. So if any of you out there know my dad, QE Mini, shout out to Dad. He is letting me chat about this, but we're actually having this conversation right now about his knee, and he is a perfect example. So clinically, his knee isn't stiff, so he's got really, really good range of movement, but he's up at night continuously with his knee, rubbing God knows what into it, and he is doing a lot of hill walking still on the farm, and he rang me last week and he said that it gave way on him up the hill. So now this has been going on for probably 2 years. He's been harping on about this knee, and if you were to look at it and look at his movement, you would say that, God, that knee isn't too bad. But actually now we're looking at the cross-border initiative to get his knee done, because as Ollie said, it's still in good shape. He's still got good strength around his quad and his hip, but he's up at night and he's not able to do the things he's doing. So those two are the indicators now for me to go and speak to to help him go and speak to the consultants about it. So to this patient, it really is about you talking to your healthcare professionals about how much it's impacting your life, and then you can make a decision on whether or not. Now, we haven't spoke about us in here. When patients come to us with knee arthritis, we focus first and foremost on getting the muscles around that knee as strong as possible. The stronger your quads and hamstrings are, than the muscles around your knee, the less force that will go through that joint on every step you take. So regardless of whether you're thinking about knee replacement in the short, medium or long term, exercise is key. And for some of our patients, they start the exercises, the knee settles down, and they don't have to, they don't have to worry about it for 6-12 months down the line. So, getting really good advice from a healthcare professional is important as well. Okay, a few more to just address here. So we have a question here that said, saw your broadcast that mentioned overuse reliance on supports recently. So that was about back pain, I would say, and the back pain supports. Would you say that heat pads that you wear around the house,
heat pads or heel pads, sorry?
Heat pads that you wear around the house should be used sparingly as well. P.S. Your new style of interactive live posts are fab. Thanks for the comment. So heat packs are a little bit different. So heat packs, do you want to? I'll stop talking.
The heat packs, they're the ones that you've got a few different types, but you've got the ones that you can actually stick onto your skin. And again, they provide relief for 4 to 6 hours, depends. You can get some of them that last a little bit longer as well, and they can be quite useful because you're on the move. It's providing a little bit of heat relief to the muscles around that area, and with that, the heat, it's dilating the blood vessels. That's the whole idea. So it's expanding those blood vessels and allowing more blood flowing into those areas, which can help speed up the healing process. But it also reduces stiffness and helps it make you feel a little bit more mobile and a bit easier to do your movements and activities. So it's absolutely fine to keep using heat. So if you're getting good relief from heat, keep using it. What you want to be careful of is if you keep using those adhesive pads, you don't want to keep putting it on the same part of the skin, because then you're going to start to get the breakdown of your actual tissue itself as well. So you just need to be a little bit careful. Just move it around to different parts, but there's absolutely no problem.
It's not the same as the back supports with the problem with the reliance.
No, yeah. So it's different. So it's not physically giving you that reliance. It's just
physiologically giving you a bit of relief. But of course, you want to see what it's no more than my dad. He heats up these heat packs for his knee, and actually I'm trying to get him active, getting his exercises going. You want to figure out why you're relying on the heat pack for the it's only a short-term pain relief strategy, really, isn't it?
But as long as you're doing some stretches, some exercises, you're getting yourself moving. And again, with those ones that you can stick on and you're moving around the house, it's a lot better than the ones where you have to sit down and actually use it, because then you're being inactive.
But really, heat pack is a short-term pain management strategy, and we're all for it as you need it.
Yeah, absolutely.
And last one, what causes soreness in the foot just under the heel? Thanks a million for this one. Catherine just came in on the comments. It's a child who's a dancer. Okay, heel pain, differential diagnosis.
If you stand on the thumbtack, that often gives you a bit of heel pain. Sorry, terrible.
So helpful to Catherine.
I know.
Heel pain in Irish dancers.
So
most common reason.
There's a few, again, it depends on whereabouts in the heel that they're getting the pain. So there's a few areas that we would predominantly see.
He's using his hands to show you, but
I'm deliberately keeping it down there. Yeah, I don't want my hands coming up in there. So if it's directly under the undersurface of the heel, we're looking at where that plantar fascia, so that big, thick, fibrous kind of ligament, is coming. So that's the tissue that supports the arch or creates the arch of the foot. So if that's coming right under the sole, right under the heel, generally, and that's quite sore, that's telling us that that's the area that's giving you the problem. That is the plantar fascia, and where it attaches to that heel bone. For some reason, it's getting really, really tight and it's starting to pull and become a little bit inflamed around that area. Now, there's another thing that you can get with kids compared to adults, and that's called your Sever's. They call it a disease, Sever's syndrome or Sever's disease. It's not a disease. It's very similar to your thanks, Catherine. It's very similar to your Osgood Schlatters of the knee, in that it's basically where the kids go through a growth spurt and the bones tend to grow a little bit quicker than the muscles themselves. So they expand at a greater rate than the muscles can adapt, and what happens is they get into this zone where the muscles are really, really tight for a short period of time, and particularly if it's compounded if they're doing activities where it's tightening the muscles even further, and what that causes is where those muscles attach to the bone, it starts to pull and become really, really sore and really, really inflamed. So I would look.
Well, also with your Irish dancers, they're often doing a lot of work where their calves are tightening up, and that can put pressure on their plantar fascia as well. So, you know, obviously when we bring them into clinic, we do a whole range. Catherine unfortunately knows as well. We would do a full range of tests to check where the source is. But I think a baseline with your Irish dancer would be make sure that they're doing that strength and stretching work on their calves.
Stretching. So stretching is massive, particularly for them if they're doing a lot of dancing. So getting them on the edge of the step. Google calf stretch. There's two types now, not just one. You want to make sure you hit both muscles, because if you just release one, you're only doing 50%. You're only getting 50% of the effect. So you want to make sure you hit both areas of the calf. Get them doing that. You can also Google plantar fascia stretch, where you're putting your toes in against the wall, or
there's a wee one where you can combine them. If you get her to do her stretch on the edge of the step, get a wee rolled up towel, push that to the edge of the step so that her toes, we should show some of these if we weren't sitting in a car park in Galway. You put her toes on the edge of the towel, toes on top of the rolled up towel, and then get her to stretch the heel down. So she'll be doing her plantar fascia and her calf at the same time. We can show you. Catherine, I'll send you a little message to show you. Okay.
But ultimately, I would start with the stretches if it's not settling. So stretches, and reduce the amount of activity that she's doing for a period of 1 to 2 weeks, and then try and start it back again and see if the pain is still there or if the pain is settled. If it's not settling, then get her in and get her seen to get it checked out. Make sure that she's doing the right things for it.
Rule always applies, guys. If you're in any doubt, absolutely get it checked out. But with those dancers, usually it's to do with their plantar fascia and their calves, so get them stretched out. Okay.
And failing that, Catherine, you can always just get out the massage cream and you can just massage her calves to loosen them out as well. Always helps. I'm sure you'll appreciate that with your back. Right.
Okay. I'm so sorry about that alarm. The car next door alarm's going off.
Someone's wrong.
Okay, that's us for another week, guys. Thanks so much for watching. So hopefully that info on knee arthritis, the heat packs, and then a little bit of heel pain helped. There was one more question about shoulder exercises. We should do some shoulder. Now, you know what? Our next Physio Live we'll do from the gym at work, and we'll show you some of these exercises. Great. Thanks, guys, for watching.
Should give you a thumbs up there.
Yes.
It is.
Brilliant.
Well done, Oren.
Well done, Oren. All right. Have a good weekend, guys. And that's us signing
We'll
off
see
from
you
Galway.
with covered in decorations next week. We'll
Oh,
see you.
yes. Watch out for the Christmas trees. Bye.
Bye.